warm welcome to everybody joining us for this evening session for the ISNTD and ADVA joint 3-day cross-sector synergies, looking at the commemoration of the ASEAN Dengue Day, which is today, and also the inaugural launch, the soft launch of the first World Dengue Day, which is also going to be taking place on the 15th of June moving forward. So a warm welcome to everybody. We've had a great 3 days. We've covered a lot of different topics, as you're all well aware, ranging from the pathogenesis, the molecular biology, the immunological landscape with dengue infection, roads out of that into treatment strategies. We've had vector control heavy presentations looking at the various mosquitoes that are responsible, the vectors that are responsible for the onset, the transmission of dengue. We've had some very, very interesting sessions yesterday looking at existential threats such as climate change, migration, emergency settings, conflict, and how they're also increasing the spread of dengue. It's really been framed as a global issue, and I think that's the take home. There is absolutely no way that dengue is something that's just confined to a certain region or the tropical belt. This is now everywhere. You would have heard throughout the 3 days, mainland Europe has in itself had autochthonous cases, outbreaks from the island of Madeira, Portugal, Spain, Italy, France. Dengue is here to stay, and that's a quote from Richard Allen, the CEO of the Mentor Initiative, who was on a panel yesterday and on our dengue advisory group as well. Dengue is here to stay. We have to adapt around that, and one of the key threads that we've picked out from the 3 days, right from the inaugural Indonesian Pediatric Society's Professor Alam, his talk, all the way through to, and especially from the ministry level input that we've had all the way through this, has been the importance of the community in terms of involving them, engaging them, mobilizing them, and moving this fight forward. It's an essential part of the overall integrated strategy, i.e. the role of the community. And it's something that we really wanted to pick up on in this particular session. I'm absolutely honored to be joined by the panelists today, and I'll give you a very quick introduction and we'll move forward. We have Dr. Hasitha Tissera from the Ministry of Health, Sri Lanka. He's joining us, he's been the first speaker in this particular session, looking at the grassroots community-led programs occurring within Sri Lanka at the moment against dengue. I think we have a fascinating insight into that. We also have, and we're delighted with this, representation of the Southern African Development Group, the SADC group, and their coordinating secretariat. They are responsible for the youth parliaments of 16 African countries. And as we've heard, not just in now, but in the previous sessions, it's a highly underreported issue, misdiagnosed. There's obviously resource issues, all sorts of negative issues around dengue when it comes to Africa, but it is there. We heard from the Ethiopian CDC of an outbreak that they were managing over the last few years and the re-emergence of dengue in Ethiopia. So we are very delighted to be joined by Maximillian Godwin, the head of the NTD task force at the SADC Youth Forum, and from the regional, and by the regional coordinator for the entire 16 countries, Misheck Gondo. They really represent the youth of Africa, and from our community perspective, a vital asset in the fight moving forward. Following those presentations, we're going to be joined by industry, as it were. We have Derek Wallace, the dengue head at Takeda Pharmaceuticals, joining us from the States, and also Jean-Antoine Zinsou, the country head, the country manager for the Philippines for Sanofi Pasteur. Very heavily engaged in all aspects of community, and it would be very interesting to have that Q&A and have that kind of have those different perspectives around community. In one of the previous sessions this morning, we had Professor Tingi Pangestu speaking really earlier about the kind of community mobilization. He was actually talking about what happens when we get it wrong. or we don't engage. And he was really referring to vaccine hesitancy specifically. However, some of the points he made around the outreach strategies, the communication modalities, the advocacy and the education awareness around those communities for dengue, vital aspects of community engagement, he made a very, very clear point. And he said, these have to be targeted, they have to be transparent, they have to be credible, and they have to be effective. And I think we are really going to pick up on that. Although he was speaking specifically about hesitancy, vaccine hesitancy, we want to widen that out to the entire community to cover all the kind of different roles it could fulfill, and this kind of dynamic that's being set up between the healthcare providers and the communities and the governments. And so we're very looking forward to this in a big way. So that brings me to our first speaker. I had the pleasure of meeting Dr. Hasitha Tissera in a government-run dengue conference, which I was invited to speak as one of the international speakers there. And that was in Lahore in Pakistan, just before, it was in January last year, before the whole COVID kind of explosion had actually happened. And I didn't realize how much of a superstar Dr. Tissera was in Lahore, in Pakistan. Even though he's come from Sri Lanka, he was instrumental in helping. It was a great example of cross-governmental collaboration in terms of the first major dengue outbreak that Pakistan actually experienced back in 2011. They'd never seen anything like this. Dr. Hasitha Tissera was flown in as part of the task force, and they've had a huge impact working together, as you've seen from the Pakistan Symposium, where they've had a massive impact on the CFR, the case fatality rate, and that is by engaging with community. There's all sorts of, steps they put in place, including the dengue tracking system, all sorts of stuff. And so he's a huge star there. So it gives me a great, we met again in Geneva after that, but a great, I'm very happy, delighted to welcome to the floor Dr. Hasitha Tissera from the Ministry of Health, Colombo in Sri Lanka. So I think I'll hand the floor over. I think it's enough from me at this point. I think we'll hand the floor over to you, Hasitha.
So I'll be talking very briefly, giving you a summary of grassroots level community engagement activities initiated for dengue control in Sri Lanka over the last decade or so. Sri Lanka has successfully negotiated some of the vector-borne diseases, as you see in this slide. As such, malaria and lymphatic filariasis have been eliminated in 2016 and 2019 respectively. Japanese encephalitis has been effectively controlled using the live JE vaccination program in the immunization campaign. Dengue and dengue hemorrhagic fever continue to remain a major public health concern as of today. If you see this slide, dengue became a nationally notifiable disease through the integrated communicable disease surveillance system that is in place since 1996, which means that nationwide dengue was made a reportable disease in 1996. Since then, throughout the previous decade, case numbers have increased exponentially. You could see how the reported cases denoted by red dots in this map of Sri Lanka have spread geographically, covering the entire country. And more so in 2009, we had a massive epidemic of 35,000 cases and 350 deaths, giving a case fatality rate of 1%. Over the past 10 years, annual incidence has always been over and above 100 per 100,000 population, with the worst ever reported epidemic in 2017, with over 180,000 cases and 440 deaths. The case fatality rate, however, which was 1% in 2009, has gradually come down to 0.2% by 2017. Nevertheless, epidemiology of dengue in terms of both biotic and abiotic factors have seen a significant change over the years. I don't want to go into details because I have another talk later on. I'll touch on that more in detail in my next talk, but I'll move on to the next slide. In 2010, based on the growing need for intersectoral collaboration, a presidential task force was established. This is the day that the task force was established by His Excellency the President. The task force brought together relevant ministries such as the local government, disaster management, public admin, education, defense, to work in hand in hand with the health ministry. This multidisciplinary partnership created at the national level nicely flowed down across provinces, districts, and the divisions, and finally reached the communities where acceptance has been very high. The overwhelming contribution in rolling out emergency response activities, particularly during outbreaks, has boosted successful community participation in vulnerable areas, using this model of a presidential task force, which was implemented in 2010. In 2004, when you go back in history, following a large epidemic, on the request of the Ministry of Health, the World Health Organization conducted an in-depth external review in Sri Lanka, which was the time that I was a registrar in public health. One of the recommendations of this committee that came from abroad was to establish a dedicated unit with an annual budget allocation for dengue control. Subsequently, the very next year, the National Dengue Control Unit was established in 2005. As such, in order to bring down and maintain a mortality rate below 0.1% from all the cases that are reported, and to bring down the morbidity level, a national strategic framework was developed with 4 pillars as given in this cartoon. It was robust dengue surveillance, evidence-based clinical care, advocacy and communication, and sustainable vector control were the main pillars of that strategic framework. A laboratory-enhanced sentinel surveillance project conducted by us in 2010 to 2000, from 2010 onwards, in the field over a 2-year period, stressed that syndromic diagnosis based on clinical parameters and simple lab tests such as the CBC count was 85% sensitive in detecting cases. Also, it found that hospitals on average were dealing with 15% dengue hemorrhagic fever, or the more severe form of dengue infection in the community. If not for early diagnosis, these patients who get more severe disease would get complicated, leading to unwarranted consequences, and even they could die of the illness. Therefore, susceptible communities, especially in endemic areas, were constantly educated on dengue illness. I'll just highlight a few key points in educating the public. One of which was early healthcare seeking when fall ill with fever was made universal. Anyone of any age, if they have fever for 3 days, a CBC was made mandatory. So all healthcare givers, both in the public and the private sector, were expected to do a full blood count or a complete blood count on any individual having fever for more than 3 days. Non-steroidal anti-inflammatory drugs and steroids were prohibited from being used for fever patients, because that was a practice back then. Even for children, the non-steroidal anti-inflammatory drugs were given to bring down fever fast. But this was counterproductive and it was being banned. And since then, the usage has gone down. Patients were given very simple monitoring charts with warning features to immediately seek attention if they were given ambulatory care, because not all dengue patients need hospitalization, particularly during the early phase of the illness. So they were given ambulatory care with very clear instructions if they see any of the warning signs to come fast, rushing to hospital. And green channels were open, as well as fever rooms were established in major hospital OPDs to cut down waiting time for those who are coming for the second time. And subsequently, small secondary care hospitals functioning without auto-analyzers and medical and pediatric wards of secondary and tertiary care institutions were given in-ward PCV machines that are seen, that is a picture of which is seen here. These machines, as well as portable ultrasound scan machines, were able to detect plasma leakage objectively in those who are coming to hospital. So middle-level doctors are now very confidently looking for plasma leakage in thoracic cavity and the abdominal cavity, and try to identify the start of the leak so that the management becomes standardized on those patients who have leaking. A more scientific real-time mapping system was established for better resource allocation as well as timely interventions in the last 10 years. A comprehensive scoring system was using the available epidemiological and entomological data with a local high-risk approach enabled the identification of the smallest geographic area for proactive action. Because of limited resources, we could not do cleaning programs or community activities in all areas, but those actions were restricted to high-risk localities. For example, some of the scoring tools that were used were population density, population of under 15 olds with dengue, the house index, the easiest indicator in entomology that can be used with least technical capacity, and existence of public locations such as schools, construction sites were included in identifying these high-risk localities. So this is one area where these geographic localities were identified, and they were used for in-depth community action. In response to this kind of action, source reduction activities for Aedes mosquito breeding was conducted over a period of 5 years, as shown in this graph from 2014 until 2018. With the Presidential Task Force providing a platform for both intra and inter-sectoral collaboration, additional manpower, which was scarce in the Health Ministry, was provided by the armed forces and the police to work in tandem with the public health officers in the field. Over the 5-year period, health authorities with military support, codenamed Civil Military Cooperation, or CIMIC in short, conducted door-to-door campaigns with the primary objective of ensuring mosquito breeding-free premises. With a short period, the active participation of the community was evident. Results were encouraging, with over 8 million premises inspected over that period of 5 years. And the Aedes breeding sites were gradually on the decline. In 2017, a unique activity took place where a team of mosquito prevention field assistants were recruited to the Health Ministry. They were mobilized in all districts to be dedicated for mosquito control activities with these SOPs that were given to them to conduct mosquito control activities under the subnational public health staff of the Ministry of Health. They were expected to work very closely with the community groups, including street committees that were established already, to engage in empowering the communities on mosquito source reduction activities. So that was one of the major activities. Here you see the recruitment day in 2017, where they were given their appointments for the first time. And this was a real, novel concept which had never been tried out for dengue control in Sri Lanka. With their help, a novel activity was initiated in all high-risk towns with a monthly collection of non-degradable products in the community by public health staff, and bringing together private sector recyclers who would buy the products from the public. Now, some of these were interesting because you can see the scrapped, warped roof gutters, which contribute immensely to dengue breeding during the rainy months. So they were scrapped because once they are warped, they collect water very easily. And once water get collected, they start breeding Aedes mosquitoes. So these are items that are collected on a regular basis now. And this allowed the people to, discard their items without much of a hindrance. Another interesting activity with the construction. In urban Sri Lanka, the population density is growing with a rapid and large demand for urbanization. Therefore, it has become essential to maintain construction sites free of mosquito breeding during the entire period of construction. Public health and built environment professionals have started to work more closely together than ever before to address this need of the day in the construction industry. Several larvicides, which were not to be the case previously, were approved to be used in stagnant water collections in construction sites and to be brought contractors were able to buy them from the open market so that they can use them in water bodies which cannot be removed easily, because you need to cure water in constructions, particularly after concreting. And in such an instant, you can't simply get rid of that water. So therefore, these larvicides were very helpful in bringing down the mosquito density. And some of the construction sites were basically in some areas were 50% positive for Aedes larvae over and over again before this intervention was introduced. So this is a novel introduction, and it has really proven the benefit of working in tandem with the community when it matters. One of the other ways of getting a sustainable community level intervention, you need meticulous planning and holistic approach to implement such activities. Introduction of a mosquito inspection card through young school children as a curriculum-based activity was expected to bring about behavioral change in families, encourage greater community participation through regular inspection of their premises. So this was another school-based activity, and in fact, it was carried forward to the homes as well. In highly urbanized areas, homes were given inspection cards where the community was asked to inspect their premises within and outside once a week and mark the potential and positive breeding places that they found. And a public health officer would go once a month to see whether these cards have been marked. And here a picture at the below right is the schools which were identified as dengue-free schools. They were given certificates. The school children and the prefects who championed those activities were given certificates at the national level. Another novel activity was by developing a mobile application for the community to report fever in school-going children, which was another step forward in this activity of community engagement. And it showed a gradual change in the community to be more socially responsible through the novel campaign, which was regularly monitored by local and higher level public health officers. And this activity actually was a pilot project which really was championed by a private mobile company which developed this tool, and the parents were expected to report this any child being febrile even before they were diagnosed as dengue or considered as dengue, and clustering of more than 3 or 4 cases in a classroom would send an red alert to the class teacher that there is a problem within that class or somewhere near that classroom. So which would generate momentum to clean that area with the support of the public health field officers. I'll take a brief time into touching on 3 ongoing research activities in Sri Lanka, which are enabling active community participation and sensitization. The Takeda vaccine phase 3 trial, Sri Lanka is a partner in that activity. We have recruited 2,100 children way back in 2015, between the ages of 4 to 16. And 4 years down the line, a phenomenal 98.2% of children still continue to be followed up after 4 years. And now I think the company is ready to give a booster dose, a 3rd dose for those children selectively. So that's another activity that has really taken effect on the community, which has really helped the community to understand the activities that is currently being tried out in terms of research to bring down this menace which is plaguing the community in urban areas in particular. The second activity is a pilot project which included Wolbachia, a bacterium, a naturally occurring bacterium, which is seen in other insects other than Aedes, of course. And here the Aedes mosquito eggs were introduced with Wolbachia, and then they were released into the community with the participation of the community groups. And there were active community engagement, including school children, in the areas where the pilot project was carried out. And there was enormous support from the community for this activity as well. And finally, a randomized trial for spatial repellents in collaboration with Notre Dame University, USA, is in progress. We have just got the necessary approvals. Transfluthrin, a common chemical compound used in mosquito coils, which have never been tested as a spatial repellent, will be used in this proper community trial, and we hope within the next few years we will get the results of this activity as well. And finally, making maximum use of the opportunity created to forecast, detect, and curtail outbreaks early. An evidence-based decision-making process was developed for dengue prevention and control in Sri Lanka. As mentioned by me in my previous slides, we worked on 3 dimensions: risk mapping, risk modification, and innovation, in addition to early diagnosis and treatment. So with this together, it summarizes a logic framework which we are using at present, to the present day, to bring down the effects of dengue in the community, in the country. And thank you very much for giving this opportunity. I can take any questions later on. Over. Back to you.